Good afternoon. My name is Camille Harris, and today I'm going to be talking about Huntington's disease. The article that I used is by Stephen Finkbeiner. I think that's how you say his name. And then this is his email information as well as the link for the article that I got my information from. Okay, what is Huntington's disease? Huntington's disease is an inherited genetic disorder that causes neurons in parts of the brain to gradually break down and die. The disease attacks areas of the brain that help to control voluntary movement as well as other areas. Many people live for many years without symptoms. After symptom onset, people live about 15 to 18 years but may live longer than 25 years. In this picture, you can see where Huntington's disease would live in the brain. So on the left, we have the normal brain section where you can see the normal frontal horns of the lateral ventricles, and then you can see the brain of someone with Huntington's disease where they have enlarged frontal horns of the lateral ventricles. Symptoms and signs. Usually, Huntington's disease results in progressive movement, cognitive thinking, and psychiatric symptoms. This includes involuntary jerking or writhing movements, or chorea, muscle problems such as rigidity or muscle contracture, which is called dystonia, slow or unusual eye movements, impaired gait, posture and balance, as well as difficulty with speech or swallowing. Materials and methods. In the article, it was found out that the clinical features of HD or Huntington's disease could be better defined by investigating genotype-phenotype relationships with greater specificity. Alleles of Huntington or HTT protein with fewer than 35 cytosine, adenosine, and guanine or CAGs were found to pose no risk for causing HD. Individuals harboring alleles with between 36 to 40 CAGs may or may not develop HD symptoms. Those that do tend to become symptomatic late in life. However, those with alleles containing expansions greater than 40 CAGs, repeats will eventually develop symptoms of HD if they live long enough. And in this picture, you can kind of see where HD will look like in a real human brain. You can see on the right we have the enlargement of the frontal horns compared to on the left they're smaller, which would be in the brain of a normal person without the disease. Results. This is our first figure, the role of the CAG expansion in IT15 on HD pathogenesis. The role, for A, which is the first one, which is this line graph up here, the study found that there is a strong correlation between the length of CAG repeat and the expanded mutant allele of Huntington's disease patients and their age at neurological onset. However, there is no correlation between CAG repeat length and the duration of the disease from onset to death, indicating that factors other than the initial trigger of pathogenesis determine the rate of progression after HD onset. And then in B, which is the constant risk of Huntington's disease, the study found that the metabolic decline in Huntington's disease patients is best described by a constant of risk of cell loss, with no significant difference in the values of A, the exponent of the equation relating metabolic changes to time. The mean value of A across the patient population was found to be negative 0.1 times 10 to the negative 3 plus 5.3 times 10 to the negative 3 mm/H1. The 95% confidence interval for the mean value of A was negative 1.7 times 10 to the negative 3 to 1.7 times 10 to the negative 3. This is our second figure. HD is characterized by abnormal protein deposits containing mutant Huntington. HD is characterized by abnormal protein deposits containing mutant Huntington. The study shows images of neuronal intranuclear inclusions, or HNIIS, and dystrophic neurites in the brain of juvenile HD patients, which prominently stained with Huntington immunoreactivity. The study also shows Huntington aggregates in the cerebral cortex and striatum of a presymptomatic HD patient. These aggregates are EM48 immunoreactive and of various shapes and sizes, with larger numbers present in the cortex compared to the striatum. Treatments. There is no cure actually for Huntington's disease, but drugs, physical therapy, and talk therapy can help manage some symptoms. For example, physical therapy can help restore muscle strength and function through exercise. Counseling and professional advice and support can help people solve problems, make decisions, and change their behavior. And there's medications such as tetrabenazine or xenazine and deutetrabenazine or Austedo that can help to control movement or the chorea that the patient would exhibit. Okay, conclusion. Even after 140 years of study, there are many unanswered questions about Huntington's disease. The genetic mutations that causes HD results in an abnormal expansion of a polyQ tract in the HTT protein, which leads to the protein's toxic functions and intracellular accumulation. Cells have mechanisms to prevent protein misfolding, but they are ultimately overwhelmed by mutant HTT. The exact mechanism by which mutant HTT causes neurodegeneration is still unknown, but reducing HTT misfolding or mutant HTT levels could be a potential therapeutic approach. Pharmacological induction of proteasome function or autophagy may be beneficial in this regard. Here we have my references and citations from the article. The figures are included in the article, and then the images that I found of Huntington's disease in the brain. Thank you so much for listening, and enjoy the rest of your day.